Welcome back, everyone. I'm so honored to be moderating today's awards ceremony to honor a phenomenal woman, Dr. Clarice Reed. And at this moment, she has graced us with her wonderful presence, and we're just going to really honor her today for her contributions in sickle cell disease. And so we're going to have our first speaker, which is Dr. Marilyn Gaston, a retired Assistant Surgeon General, fellow sickle cell champion, and close friend of Dr. Reed, who will give a personal introduction. Dr. Gaston.
Good afternoon. What a wonderful audience. I thank all of you for coming. This is wonderful. Shows how smart you are. I want to first thank all of the staff and also the government for giving Dr. Reed this wonderful and well-deserved award. Thank you so much. It's certainly well-deserved. And I'm delighted and honored to have the opportunity to introduce Dr. Clarice Reed, an outstanding physician, respected administrator, outstanding mother, grandmother, outstanding human being overall. She's truly a phenomenal woman. I've known her for almost 60 years. I know I don't look that old, but that's... It started when I was finishing my pediatric residency, and she has had a major impact on my life as a mentor, best friend, teacher, boss, advisor, and really a sister. She's been like a sister to me. Her professional training has been outstanding, including degrees and training from Meharry Medical College, Talladega College, University of Cincinnati College of Medicine, Jewish Hospital, I have to rest for a minute, and Children's Hospital Medical Center in Cincinnati, Ohio. And as many of you know, it was very unusual at that time in our nation's history for a woman to achieve any of these accomplishments, not even one. Not even one. Just think about that for a minute. Anyway, she, as many of you know, after completing the training in Cincinnati, she began her solo pediatric practice in Cincinnati. Dr. Reed was very active in everything: medical training, teaching, working in the well baby clinics of the city, underserved areas. She was also appointing chair of the whole department of the Jewish Hospital to show their respect for her information and her as a businesswoman. But then her career changed when her husband, lawyer Arthur Reed, accepted a 2-year appointment in the Office of Economic Opportunity. Oh, do all of you remember EEO? Yeah, okay, that was a very important organization. They did a lot of the things in terms of our revolution. And they relocated to the DC area, and this move launched her federal career. She was medical director and later deputy director, administering the screening and sickle cell disease education clinics in the government programs that were going on. With a short period of time, the director of the Blood Institute at NIH, Dr. Levy, appointed her director of the entire National Sickle Cell Disease Program. She was really smart because she began first with the initial focus on sickle cell centers. These were programs that they presented and did everything. They did screening and counseling and research and care and everything. And the good news, the major focus was on the sickle cell disease patient. A lot of programs aren't really focused on sickle cell, on the patients that they're taking care of, but this one she knew had to happen. Also, she brought together closer interactions between basic and clinical investigators, uniting the community and academic centers, which needed really to happen at that time, uniting those two major partners around one health program, sickle cell disease, and also developing leaders and careers of young investigators so that we're constantly growing people that knew sickle cell disease. Because back then, that wasn't taught in medical school. I didn't learn anything in medical school about sickle cell disease. I learned it all after I got out and was in the hospitals and sickle cell disease learning it. She was chosen as director of the NIH Division of Blood Diseases and Resources, which included programs for all the blood disease. Every blood disease in the country was under her purview. And clearly, she was the first black woman who ever received such an honor at NIH. That was a major first. And needless to say, we were so proud. We were walking around with our chest stuck out, like we had done something, but we were so proud of her. And she was the first black woman to be a director of the NIH division. She was the focal point for 18 years for the country's sickle cell disease research and scientific initiatives, sickle cell disease treatments and approaches, the integration of community programs with clinical and basic research programs at NIH, and always, always focusing on impacting on the lives of patients and their families. She retired after 26 years of government service in 1998. And needless to say, she's received numerous honors and awards, both by civic and scientific communities for her exemplary leadership. For example, the Public Health Service Superior Service Award. She was honored by Black Enterprise magazine as one of America's leading black doctors. She's an outstanding woman in medicine as part of the National Library of Medicine's traveling exhibit. And by the way, she's an outstanding Briz champion. Nationally, okay? I think her husband was 1 and she was number 2. Is that the way it was, Claire? Or you were number 1 and he was number 2? I don't know. But anyway. And let me tell you something. The success and longevity of the sickle cell disease program and research programs were related directly to Dr. Reed's leadership. Her programs were directly related to her passion, her intelligence, her advocacy, and her never give up attitude. I don't know how often both of us went to the director to ask for some more money. And I would say, well, Clarice, I'm just ready to give up. She said, oh, we're not giving this up. No, we'll figure out how to get it. And she was always ready to figure out how she could solve the problem. And remember now, she's doing all this with also her roles as wife, mother, and grandmother. Clarice, thank you for all that you've given to the sickle cell community and certainly given to me. And I pray that God will continue to bless you as he has blessed all of us through his gift of you. Thank you.
Thank you, Dr. Gaston, for your beautiful remarks. Now, without further ado, it's now my pleasure and honor to introduce Admiral Rachel Levine, the 17th Assistant Secretary of Health, who will present Dr. Reed with the Assistant Secretary of Health Exceptional Service Medallion. Thank you.
Good afternoon. It's a real pleasure to see you all today. I am Assistant Secretary for Health, Admiral Rachel Levine, and it is my distinct honor to present the Assistant Secretary for Health's Exceptional Service Medallion to Dr. Clarice Reed for her remarkable contributions to millions worldwide living with sickle cell disease and for transforming the landscape of sickle cell disease care and research across our country. This prestigious civilian medal recognizes outstanding achievements in public health and medicine. It is the highest civilian award from the United States Public Health Service, which encompasses all of the agencies of the Department of Health and Human Services. As you have just heard from Dr. Gaston, Dr. Reed truly deserves this recognition. A trailblazer in the field of sickle cell disease, Dr. Reed spent over 2 decades leading the National Heart, Lung, and Blood Institute's National Sickle Cell Disease Program from 1975 to 1998, making her the longest tenured program administrator in NHLBI history. Yes, please. Under her leadership, the program oversaw the initial appropriations and implementation of the National Sickle Cell Anemia Control Act of 1972, marking the first federal funding for sickle cell disease. This monumental step laid the foundation for progress that have saved countless lives. Dr. Reed championed landmark studies on newborn screening, which led to universal screening in all 50 states by 2006. Thanks to her and Dr. Gaston's efforts, routine penicillin prophylaxis for children with sickle cell disease became a standard practice, contributing to a near 100% survival for affected children in the United States. Thank you. Dr. Reed expanded the Comprehensive Sickle Cell Centers program, instrumental in pioneering advancements in research and clinical care. She also established the Cooperative Study of Sickle Cell Disease, a groundbreaking study that has deepened our understanding of sickle cell disease genotypes and phenotypes. Beyond her professional achievements, her journey is truly inspiring. As a product of a segregated school system in Birmingham, Alabama, she rose to become a general pediatrician, which means a lot to me as a pediatrician, and the 3rd African-American graduate of the University of Cincinnati College of Medicine in 1959. More recently, Dr. Reed was a panelist at Secretary Becerra's Sickle Cell Disease Trailblazer event in April 2024, just a few months ago, continuing her legacy of leadership and advocacy. So today, we honor Dr. Clarice Reed, not just for her remarkable career, but for her profound impact on countless lives, including many warriors, mentees, and advocates here in the audience with us today. Dr. Reed's contributions and service to sickle cell disease cannot be overstated. So please join me in celebrating Dr. Reed's dedication, her passion, her commitment to improving the lives of people with sickle cell disease everywhere. Thank you.
Now we'll have a token from Lakia Bailey to Dr. Reed. Before you speak.
1 second. Sorry, 1 second. Hello, I'm Lakia Bailey, a sickle cell warrior.
I'm Yolanda Lewis, a warrior caregiver.
And on behalf of the sickle cell patients and caregivers of this community, we want to say thank you for all of your work and dedication. These are just a small token from us, from a grateful community.
Thank you. Okay. Well, I think I'm getting too much credit here.
Good afternoon. And what a glorious day. And it's September Sickle Cell Disease Month. I want to thank you, Dr. Bailey, for these beautiful flowers and your words. I'm grateful beyond words. And to you, Marilyn, Dr. Gaston, for your glowing introduction and heartwarming words. Brought back lots of memories of times gone by. And a special thanks to you, where's Admiral Levine? Oh, special thanks to you, Admiral Levine, for this esteemed honor of recognition, the Exceptional Service Medallion. Picasso said, and I quote, "Some of the best works come in the last half of our lives," unquote. This is my Picasso. And it's special receiving this highest award at this stage of my life. Makes it even more meaningful. It brings with it mixtures of emotions of joy, happiness, thankfulness, and abundance of gratitude. Everyone likes a good surprise, and this service medallion fits in that category. My years as the public health servant and working at the NIH brought me unadulterated joy. It was divine timing that my career pathway did a 360-degree turn from taking care of children in Cincinnati and pediatrics and landing at the door of the National Institutes of Health and the National Sickle Cell Disease Program. My first 3 years were at HRSA in the Sickle Cell Disease Program there with screening and education clinics, and then to the National Institutes of Health. I won the lottery. It was the best of times. We are all rightfully proud of the many successful moments of the sickle cell disease story, but be reassured that none of these are mine alone. We must give credit to our predecessors whose early findings led to this modern area of sickle cell research, laying the groundwork and illuminating the path to progress for decades to come. None was more exciting than the 80s, with the explosion of molecular biology leading to new techniques in gene mapping, DNA sequencing, prenatal diagnosis, reactivation of the globin gene, and many others. There were major successes in research. This extraordinary award must be shared with all the parents who for 20 consecutive years brought their children to participate in clinical studies. For the 4,000 patients who made it possible to identify the natural history of sickle cell disease, the many investigators and clinicians who joined together and bringing their expertise and experience to a high level of sickle cell disease from the shadows of obscurity to the prominence in the sickle cell community. For the nurses and health educators and the entire sickle cell community. And last but not least, the unwavering support of the late Dr. Claude L'Enfant, Director of the National Institutes of Health. This award confirms that the investment in basic and clinical research, clinical trials, collaboration with community groups, and training young investigators paid unparalleled benefits and will continue to do so. Receiving an award of this stature allows me the opportunity to reflect on the lives we have saved over many generations of the sickle cell warriors who are living long and more productive lives. It is an exemplar of hope for the possibilities of additional medical breakthroughs, expanding beyond the sickle cell gene therapies recently approved by the FDA, where I had several sickle patients land in this study. We are now, importantly, advancing the new sickle cell studies that we have piled a long time ago. I'm looking for my last page. I'm very inspired by the presentations here today and the passion and enthusiasm of this audience. The future looks bright because of you. May this award prompt all of us to think about what we can do to make this a better world, one in which our names are not echoed on the walls of history, but our everyday words and actions toward others might make an indelible mark on their lives. What a great gift to bestow each day. I want to thank my family. I have family out there, you may stand. My son and daughter-in-law. Who joined me today for this auspicious occasion to receive this incredible award. Thanks again to Admiral Levine and the Department of Health and Human Services for my Picasso. Thank you. Celebration for this incredible award that I have, a prestigious award which I did not have any idea that it would be given to me at this time, but some of the best works, as I said, comes in the last chapter of your life, and this represents that for me. And I want to say that I was unprepared for receiving an award at this stage, but it really feels good.
That's hard to follow. She's really funny. And while we all get settled in, it is my distinct honor to introduce another true champion for sickle cell advocacy in our nation. Representative Danny Davis, representing Illinois' 7th Congressional District, has been a tireless advocate for sickle cell community for well over 50 years. As co-chair of the recently established Congressional Sickle Cell Disease Caucus, he fights to raise awareness and champion changes that support sickle cell warriors nationwide. Please join me in welcoming Representative Davis to the stage.
Well, thank you. You know, I've been told that life is but a minute, just 60 seconds in it, forced upon us. We didn't seek it, and we didn't choose it. But thank God each one of us can determine how we use it. We suffer if we abuse it. Just a tiny minute, but eternity is in it. Let me first of all thank Secretary Becerra. I don't know wherever he is, wherever he's at, but whatever he's doing, I want to give him thanks for the tremendous job that he is doing as the Secretary of the Department of Health and Human Services. I also want to congratulate both of the award recipients who have done outstanding work for a long period of time and deserve the accolades that they'll be given this afternoon. And I have to confess that one of them I had the good fortune of working with admiring. We'd clap whenever she would come because she too came through the health center group. Dr. Marilyn Gaston, it's just so good to see you again. And to remember those early days and all that you meant to all of us who had hope and recognized possibilities. My journey involving sickle cell disease and the trait began in 1969 with one of my first jobs as the director of training for the Martin Luther King Community Health Center in a place called Chicago, Illinois. And I've been engaged with health and sickle cell since that time. That is where I learned about the significant role that our safety net providers play in delivery of health care, which are now commonly known as medical homes. In retrospect, even 5 decades later, they were practicing even then the cutting edge of humanity in the delivery of health care. To illustrate it, many of our centers at that time, every African American patient was tested for sickle cell disease and the trait as they came to the center. If a patient indeed was diagnosed with the disease, we entered them into treatment. And if they exhibited the trait, we used this as an opportunity to raise awareness of what could happen if that patient had a child with someone else who is a carrier. While this may seem like a small gesture, it helped to decrease overall incidence rates of the disease burden, but even more so, it empowered parents to make important decisions about the life of their children through screening and prenatal testing. Some of the challenges sickle cell patients face, as you know, range from discriminatory practice that meet them square in the face in the emergency room, simply because they're in the midst of a vaso-occlusive crisis. They also experience chronic pain that can lead to the stigma of drug-seeking behavior. Patients with sickle cell experience a multitude of health complaints, along with associated behavior needs, resulting in them sometimes not being able to work. This directly impacts their ability to obtain quality health insurance, prescription drugs, and coordination of care, not to mention the sickle cell patients who live significantly shorter lifespans, with women living an estimated 48 years and men 42 years. Not only is this unacceptable, there is much work that needs to be done to level the playing field for research, parity, for sickle cell that closely mirrors cancer, diabetes, and other chronic illness. I was fortunate to work with a physician, Dr. James Edward Bowman, who, by the way, is also the father of Valerie Jarrett, who worked with President Obama, and with Dr. Maurice Rabb. One ran the sickle cell program at the University of Chicago. The other one ran the sickle cell program at the University of Illinois at Chicago. And as a result of their advocacy and the advocacy of others, in 1972, President Richard Nixon signed into law the National Sickle Cell Anemia Control Act that appropriated $10 million in federal funding to provide federal programs that screen, counsel, and help patients on sickle cell anemia who had the problem. Support, information, and education was also made available, the first real time. But you might also note that since then, we've come a long way. Because since then, when I started work with federally qualified health centers, there were 10 of those in the United States of America. Now there are 1,400 serving 30 million low and moderate income people. And so when Dr. Reed and Dr. Gaston say that working in health was the favorite work that they've done, because if I've been around these institutions and at one time used to be the president of the National Association of Health Centers, it's been the most desirable work that I've done. And I've done a lot of things. I've been a lot of places. I've been all over the world, I guess. But that has been the most satisfying work that I have done. In Congress, we've done things that we think have helped move the needle. In 2004, Senator Jim Talent and I, along with our colleagues in Congress, introduced the Sickle Cell Disease Act, a bill designed to do more to improve the treatment and prevention of sickle cell disease. Specifically, as part of the American Job Creation Act, this bill was enacted, and in the 115th Congress, Senators Tim Scott, Cory Booker, myself, Representative Michael Burgess, and Representative G.K. Butterfield, as well as Barbara Lee, sponsored the House companion bill to the Senate and supported a bipartisan and bicameral bill, Senate Bill 2465, the Sickle Cell Disease and Other Heritable Blood Disorders Research, Surveillance, Prevention, and Treatment Act of 2018. This authorized law had continued to improve the treatment and preventive measures to reduce the risk factors in sickle cell. Then we introduced last year in December of 2023, and just the other day, we had another bill, H.R. 3884, the Sickle Cell Disease and Heritable Blood Disorders Research, Surveillance, Prevention, and Treatment Act. And of course, that again was Dr. Burgess from Texas, a Republican, myself, Representative Barbara Lee, and in the Senate, Tim Scott, Cory Booker, and Raphael Warnock. Yesterday, it was my pleasure, it is my pleasure, to inform you that H.R. 3884 was unanimously passed and As I conclude, I want to thank Commissioner Martin O'Malley, the secretary handling this great big program called Social Security. And I want to thank him for addressing an issue that I discussed with him last February, about children who are disabled by sickle cell disease, not being able to access supplemental funding from the Social Security Administration for benefits due to the high benefit of denial rates under what has been currently regulations disproportionately harm has come to black children, especially in low-income families with severe health challenges. He has informed me that he has created a task force committee, and they're going to have a report pretty soon, and they're going to deal with this issue in a real significant way. So I thank him profoundly and profusely. I end by suggesting that life gives to each one of us whatever it is that we would endeavor to make life be. And while there are still many health challenges, there are many opportunities and elements in terms of moving the needle. I'm old enough, Dr. Gaston is old enough, Dr. Reed is old enough to remember when some of the treatment modalities that we currently use did not exist. I lived in a county growing up that had one physician, one doctor, and he reminded you of Doc Adams on Gunsmoke. But he had a T-Model Ford, and so he didn't have a buggy, but you could tell when somebody was sick because you'd see the dust from his car, practicing medicine. I could not end by saying that we still have a tremendous shortage of African American practitioners, of physicians and nurses. And I'm hoping, I'm believing that this new administration we're going to get after we create it in November, we're going to see some serious movement in those areas, because I have the hope and recognize the possibility and end by saying life will give us whatever we want. The poet said it this way: I bargained with life for a penny, and life would pay no more. However, I begged at evening time and counted my scanty store. But I found that life is a just employer. He gives you what you ask. But once you have set the wages, then you must bear the task. I worked for a menial hire, a penny, only to learn dismayed that whatever price I had asked of life, life would have willingly paid. Thank you so very much, Dr. Gaston, Dr. Reed. You all have a good evening. Thank you.
Thank you so much, Representative Davis. For our final session today, we have all warriors. Our four speakers will be discussing quality of life for those with sickle cell disease. And quality of life is about addressing not just the immediate medical needs of our warriors, but the emotional, the mental, the educational, the workforce-oriented, everyday experiences of those living with sickle cell disease. This session will be led today by Lakia Bailey, warrior and executive director of the Sickle Cell Consortium from Cumming, Georgia. She'll be joined today by Mariah Scott, warrior, mother, and doctoral student at Rutgers University in Piscataway, New Jersey. Our next speaker is Servio Estacio, warrior and entrepreneur from Miami, Florida. And last but not least, Christelle Solomon, warrior, transplant survivor, and health policy and education analyst at the UCSF Sickle Cell Center of Excellence in San Francisco. Please join me in welcoming them.
Well, all right. Hello, everyone. Thank you all so much, and thank you to this committee, to HHS, for having us here and allowing us warriors to wrap out this very important meeting. We're very excited to be able to share our perspective and our focus and about quality of life specifically and what it means to us, why this is such an important discussion to us. I am Dr. Lakia Bailey. I'm the Executive Director of the Sickle Cell Consortium and an individual living with sickle cell disease. And I am so excited to be joined by these three amazing individuals. And we're going to start with getting a little bit of a brief introduction from each of them to share a little bit about yourself, where you're from, and anything you'd like to share before we jump into the conversation.
All right, I can start us off. Good afternoon, everyone. My name is Christelle. I'm a sickle cell warrior. I was born with hemoglobin SC. I'm also a transplant survivor. I am 2 years and 10 months post-transplant, so super excited. It's crazy to think about. And I work for the UCSF Center of Excellence and the Alpha Clinic to help leverage social media as a means to empower sickle cell warriors by creating health education content and bridging the gap between doctors, scientists, and the sickle cell community. And so before I got on this journey of being, doing the work that I do now with my own transplant team, I actually was training to become a physician. And this is important for me to share because it kind of has helped me to reflect on what I consider quality of life and thinking about the intersection between the medical system and quality of life, for warriors. And so when I grew up, I went to the hospital a lot, as you warriors know. But even though I had a lot of physical challenges with my health, I still felt really supported by my providers. I felt cared for as a whole human being. And that really played a big part in me feeling like I still had a full life. But as I transitioned to adult care, I felt like my quality of life was decreasing. And originally I thought it was because my acute problems were becoming more chronic. And of course, you got bills to pay, have my cat to feed. But in reality, I felt like the support that I had from the medical system was no longer there. So instead of feeling like a human being who was going to the hospital to receive care, I felt like a criminal. I had doctors tell me all sorts of derogatory comments, lots of accusations without asking me any questions about my medical history. And it made me feel like a burden to the system. And that actually was the biggest deterrent to my quality of life, because on top of the health issues that I was already experiencing, having to take a break from medical school, I also felt like I was being dehumanized by the same people who I was going to seek care from. And it all makes sense because when I went to medical school, I realized that you don't really learn anything about sickle cell disease. And out of our thousands of lecture slides about hematology and oncology, there were 5 about sickle cell, and only one of them mentioned the word pain with no context. And so as I'm putting this together, warriors, we're so strong, we're so resilient, this community is so beautiful, and we want to fight. We do fight for our quality of life, but there's a cap. The medical system can be a cap to that. I can only reach a certain level of quality of life if you see me as a human being, if you see me as receiving care. I can advocate for myself as much as I want to, but I cannot place orders at the doctor's office. I cannot send a referral. And so I just want to encourage us as an institution to think about how we can empower providers to empower us as patients, how we can think about partnership and really delivering comprehensive care to warriors. And so I appreciate you listening, and I'm so happy to be here.
Thank you. Servio?
Hi, good afternoon, everyone. My name is Servio, and the reason why I'm here is because I would like to share my stories and a different and unique perspective as far as quality of life and living with sickle cell anemia. As a person who has been impacted both personally and professionally, I just want to help other sickle cell warriors by advocating for their health and telling other people, including caregivers and other sickle cell warriors, to speak up whenever they see any type of injustice toward any sickle cell patient, and also to give you a unique perspective to try different things and to find your comfort to increase your quality of life.
Thank you, Servio. And Mariah.
Good afternoon, everyone. My name is Mariah Jacqueline Scott. I am a sickle cell warrior from New Jersey. I'm so happy to see New Jersey in the house. My quality of life, and first of all, thank you, HHS, for inviting us, because I truly adore this panel, because throughout my journey with sickle cell disease, I have 2 hip replacements, 2 shoulder replacements. But really what started my journey and quality of life was I had a OBGYN tell me I have no business getting pregnant because of my risk of dying too high. And that was one thing. I wanted to be a mother. And it actually made me so depressed, I stopped working and I stopped going to school. But throughout that whole journey, no physician said, are you depressed at home? Are you going to work? Are you going to school? The things that are you going out with your friends? Do you have a social circle? No one asked me that. And it wasn't until I pursued a second master's in epidemiology, some people will call me the data girly, because that's when I learned about patient-reported outcomes and how that can paint a picture of quality of life. And in sickle cell disease, especially in the pediatric to adult care transition phase, we really need to paint that picture and show that picture of quality of life, because that's our story. That's what makes us me. That's what makes Mariah and Servio and Lakia and Christelle. That's what makes us all one person. So I'm just so grateful to be on this panel and share my story with you.
Thank you, Mariah. And I am Lakia Bailey, and I have, I'm also a bit of a nerd, and I tell people I'm a nerd, embrace your nerd. And I have my doctorate in molecular hematology and regenerative medicine. And I am really excited for us to start right there. I was diagnosed with sickle cell disease when I was 3, and at the time, my mother was accused of having Munchausen syndrome. The doctor thought that she was doing something to hurt me, to cause pain, and it finally took a specialist to be diagnosed with sickle cell. And the quality of life question comes up immediately. My mother was told that I would probably never be as sick, not to worry about it. It most likely wouldn't be a big deal. And so the very first time, hand-foot syndrome, where I was admitted, my mother, when they said she has to go to the hospital, she told me she thought they were joking. She was not prepared for that, nor what it would mean raising a child with sickle cell. And so I am really excited to be joined so that we can really jump into this conversation. And Mariah, I'd love to start with you. You are in research and the clinical programs. And what does quality of life mean to you first? And then how can it be better prioritized in the clinical research space?
I love that question. The way I see quality of life, it's like an umbrella. Everyone's umbrella is different for each warrior, and even caregivers. I think in this conversation too, we need to include the quality of life of caregivers, especially economically and mental health. So right now I'm pursuing a doctorate, that's how I got the nickname Professor Scott, in prevention science, which is a combination of psychology, public affairs, and public health, which is kind of like sickle cell right now. This is like the voice of sickle cell. And using patient-reported outcomes as showing what happened at home. So how can I go from mothering in the bed with my 3-year-old daughter watching Law and Order to being a mother in the park or being a mother outside? How can I, because of my chronic pain or fatigue, of fatigue something that we're not really talking about or including in our research. How can I go from not being able to contribute to rent with my fiance in order to pay a $600 drug treatment per month? Those are the things that are not included in quality of life, which needs to be in policy. So when you have access, we talked about access to care. And the best way to include that, and I think we heard that earlier, is really the patient voice. You're having a clinical development of a new drug, get those patients in the lab and say, I need you to address my fatigue, my chronic pain, so I can go to school and work and be a mother. In policy, I need more programs so I can access my drugs and not pay almost $1,000 per month. And really trying to not only, or with our national organizations, but also our state organizations, really into the community and get down in there and say, what does the community need? What do warriors need? What do caregivers need? And I'm hoping the goal from today or even from this panel is just, I want to see us also, keep surviving, but how can we keep thriving in life and achieve our careers and our dreams of being families and doctors and nurses or whatever it is.
Thank you for that. I would love to hear from you as well. What does quality of life mean to you, Servio? The male perspective is one that is quite often sort of overlooked, but we've learned that living with sickle cell as a man is a very different experience than living with it as a woman. From that male perspective, what does quality of life mean for you? And what do you see as a way it can be improved in this space?
So being a male and having sickle cell anemia, you have to take into consideration that even though you do have sickle cell anemia or sickle cell disease, the requirements of what a man should be are still there. So the way that I see quality of life is to find your comfort. So it's locating and identifying everything that you're not happy with, that is not working for you, is not serving you in the way that it should, that it's intended to be, and basically replacing it with something else. So just to give you an example, we all know that sickle cell disease carries a unique challenge as far as working is concerned, and studying and just going to school and living a normal life in that aspect, in that not all sickle cell patients work 40 hours a week or are able to, and not all sickle cell patients are able to do 12 credits every semester. So this challenge, it became a problem for me in the sense of when I was going through a very difficult period that I had to see a lot of doctors and a lot of specialists. I was working for a company and I had exhausted all of my PTO. And then I had requested another period of time in which I needed to go see another doctor for about 2-3 hours or so, and it was denied. That's when I realized that, I can't be the only one that's experiencing that, and I decided to just seek my comfort by resigning and going self-employed. Mm-hmm. And through self-employment, I'm able to, through structure and also having a support system, basically create my own schedule. What works for me is to write down basically all of my appointments and what doctor it is on what day and the address. That way I have all the information that I need at once. And then schedule my day accordingly and then make up the hours at another time, which is a very difficult thing to do with most employers. Mm-hmm. And through that, I'm able to have the peace of mind knowing that I'm able to complete my job, but also take care of my health at the same time.
Thank you. I would also, before we get into some of these other questions that we had, you've gone through the transplant, and I'm curious what aspects of quality of life? First, what does that mean to you? And then was that taken into consideration? Was that part of the decision to undergoing this process? And what was that like for you?
Yeah, quality of life to me means a fulfilled life. And so it's individual. So each person has a different definition of what brings them fulfillment. And for me, fulfillment is being able to spend time with family, being able to pursue my dreams, and being able to live a life where I can go outside and go for walks. And when I was really struggling with my health, I felt confined. I felt like I had to be inside all the time. Everything hurt. And so I feel like there's a constriction that comes with some of the sickle cell symptoms. And so quality of life means being able to have more freedom, to live in the way that I see as most fit. And the second question is very important. And I do believe that my quality of life was taken into consideration when I made it to my transplant center. But before then, I felt like I had a difficult time conveying to providers the lack of quality of life that I actually had. I felt like no matter how much I was saying, like, hey, like I have not left my house, or I can't drive, I can't do my laundry, everything is a hassle. Doing my own hair, I just started paying people to get it done because having my arms up and detangling, that's too much. And so I felt like even though I said those things, the providers would just be like, well, your kidneys are not really failing that bad, or the AVN is just starting. It's like not that bad. And I think before I made it to my transplant center, I had a hard time feeling like I could get providers to believe that my quality of life was something that mattered, not just the numbers on my labs or the like diagnostic testing. I do feel like I was in such a rush. I was so desperate to get the transplant that there were certain things about my quality of life that I did not really take into consideration. Like thinking about fertility preservation, I didn't know if I wanted kids, but I was like, that's too much time. Like I don't want to think about it. But that's really not the way I think we should approach it, because quality of life matters before any transformative therapy, during the transformative therapy, and after. And so. Can I say one more thing? Sorry. And I also felt like I didn't realize how much I would have to take into account my quality of life after transplant. I thought that I was just going to be cured, and and if it worked, because I knew that was a potential that it could not work, or that I could die, or something horrible could happen. If it worked, I would just be so happy. But it did work, and I was not happy because I had to walk away from my career dreams. I felt like I was lost. I was like, am I a sickle cell warrior anymore? I don't know. Does that count? Just seeing other warriors suffer and feeling like I had survivor's guilt. So there are a lot of things to take into account when it comes to transformative therapy and quality of life.
You know, I'd love to get into that a little bit more. I've had similar experiences with the fight for fertility preservation, and I had to genuinely fight to get them. My experiences with curative, or we don't really use the term curative so much anymore. We have transitioned to transformative therapies, because curative puts in mind this idea that cure, it's all gone. It's no longer in my DNA. I won't be passing this on to children. I've had bilateral hip replacements. That's not going to go away with these therapies. The damage to my lungs, all of these are not going away. And I think the term curative is a bit tricky, and I don't know that it helps us to manage expectations that you're not just instantly better when you undergo these. But one thing I've noticed that's uncommon here was freedom, for one. Freedom to have children, freedom to work as you want, freedom to live as you want, and the battle to obtain that with this disease holding us down. But also it feels a little bit like you all are saying it was the providers as well that were not allowing you. We shouldn't, I don't think we should have to fight this hard to find out these options exist. I also don't think the burden should be on us to find out these options exist. That I know that we have taken it onto ourselves. community-based organizations, patients, caregiver advocates. And so I would love to hear a little bit more about that and about how we can turn these discussions, someone said that today, turn these discussions, I think it was Mary Brown, into action. What do we need to do to stop this from being conversations? Because it's very repetitive. I feel like we have these conversations a lot. How do we transition these into actionable items that can improve our quality of life while we seek out the freedoms that we need? And I'd love to hear from any of you about that.
I think quality of life workshops from our individual perspective, from our angle, and also this can start seeing some positive change through the foundation that is education and the government, because just one of my experiences, I did call a hospital one time because I just wanted to know how long was I going to be kept, depending on what the diagnosis would be. And I spoke to the nurse, and I asked the nurse, if they did an x-ray, how long would I stay if I had acute chest syndrome? And the nurse told me that she didn't know what that was. And I told her she should ask her manager, and then I just hung up. And I ended up going to the hospital anyway. But that's part of the problem, where it all begins, because if something as life-threatening as acute chest syndrome, a medical practitioner does not know that, then that's something to be of concern, and that's an indication of where improvement could start.
Also, too, I think sometimes, unfortunately, we end up being reactive. So we're getting poor treatment in the hospital. We're being poorly treated by a physician. We report it to the board. We're going to the hospital board, CMOs, board of directors, or we're having a problem with the insurance once we get the denial. But sometimes, it helps to be a little proactive. So a little background, a couple months ago, my old hospital removed narcotics from the outpatient infusion center, all because of a sickle cell patient was, quote unquote, misusing the protocol. So now that affected all of us, and it's either address your crisis at home or go to the ER. Now, I live in New Brunswick, New Jersey, which is, they call it like the armpit of New Jersey. And I go to Rutgers Camden, that's an hour drive. So now I found an amazing hematologist by school, but now my care is an hour away compared to 30 minutes. But before I went to Camden, I said, what is your protocol for pain management? Who are the people that, if I have a problem at the hospital, I want to have that whole list before a problem occurs, and kind of put my face and say, hey, I'm Mariah Scott, I'm here, I have sickle cell, what do you do? To really kind of face forward, and we're all called warriors, go in the front lines of this and head on straight and say, hey, I'm here, I want to know, what are your policies? What do you do for this treatment for sickle cell disease before it gets too bad?
That is such an excellent point. And I do agree that I wonder if it would be useful if there was some training on the questions to ask. And sometimes we aren't aware as warriors, what are the questions that we should be asking in order to safeguard our own quality of health, of life. You were about to say something, Chriselle.
Yeah, it's slightly different. I'm going to pivot just very quickly. The thought that I had in mind in terms of how do we make the change actionable was thinking about how to, there's a standard of care and it's documented everywhere. Maybe not everywhere, but let's not use that. But most places, a lot of really important sources that are evidence-based and people rely on for other medical care. But it's somehow the application isn't standardized, and there's also no accountability at these institutions that offer care, like calling the hospital and having someone just like have no idea what acute chest is. So I would say like starting from the root is educating the medical trainees to actually have a certain level of education about sort of some of the broad concepts with sickle cell, and then being able to be okay saying, hey, I don't know this much, so let me refer you out. And that's an issue that I feel like hasn't been, that I've encountered a lot. And then also some sort of, I don't know how to employ this, but some sort of, in terms of applying accountability, like there is a standard that needs to be applied for patients, and if it is not met, this is how we're going to hold an institution accountable, or this is how we're going to fix that system. And I feel like if for other disease groups, let's say, like there are other issues that are lacking. I feel like if you deny a patient who has cancer chemotherapy, that's like not acceptable, totally not acceptable. If you deny a patient with type 1 diabetes or type 2 diabetes with insulin, that would be, as like the medical oath term, it would be maleficent. It would actually harm the patient. And so that should be like a no tolerance, because that's part of the oath that we take that you take as a provider. And so being able to really instill something like policy-wise that would account for maleficent actions, even if they're unintentional, because most of the time they are. Like, you don't go into medicine wanting to hurt people, but it does have action. It does have a consequence, and so being able to standardize some sort of practice for repercussions for those actions. But what you had thought about, what you had mentioned about questions for the patient to ask, that's actually interesting, because I feel like it's hard for me to ask something that I have no idea about. And so that was just like sparked a thought in my mind. I was wondering what you thought about that.
I agree with you, and I think it might be interesting to have further of these conversations. You mentioned, so one, a standard. I am aware that there is some work that's going on now about what it would look like for the standard of care for institutions. We as patients and caregivers defining our standards as well. What does it look like for us? When those standards are often designed, they're based on what a provider would want to see in an institution. And sometimes it is our voice as the patient, and equally as important, the caregiver, that is often overlooked. Each of you have sort of mentioned a little bit of not being heard by job, by providers, and I would like to talk a little bit about that feeling of helplessness. And when you are faced with the feeling of helplessness when it comes to your own health care, that is a particularly horrifying place to be in. And you have talked about how you had to sort of fight to be heard, that you even needed access to these treatments and therapies. Can you talk a little bit about that? Any of you?
So from my perspective, just speaking to an employer, it can sometimes be very defeating, and there can be a sort of sense of betrayal, because you know that you have 100% of the intention, but not 100% of the capacity to do what the average employee is able to do. So it can be defeating to be, just expressing concern and urgency and just not being heard from that angle, because not every single sickle cell disease patient has a degree or a manager role that provides unlimited PTO. I mean, that would be the only way to go around that, but that's going back into the issue of not being able to finish school or not being able to do it in just a standard timeline of how these programs have been created. And sometimes you just have to just think about it and have like a support system to go over these things and weigh your options as to what is it that you can do in order to improve that particular situation.
What about you?
Yeah, and I get it. Like, there are many times I don't want to call the insurance. I don't want to talk to this doctor. I don't want to report again. It's like, I felt like a hamster in a wheel, just keep going and going and going, and it's like nothing happening. But, heard community a lot today, and I think that we are all fighting together on this, and if it's not helping me, it's helping someone who's sitting next to me. It's helping someone coming behind me in another state, in another county. And, you know, and I get it sitting there on the computer looking for how do I address this, or what number to call, or any of those things. But again, going back to tools or training, or even more these conversations and actually working together could really help us try to advocate this and try to get ahead of it before it gets any worse.
So.
And I wanted to piggyback off of something Mariah said earlier in terms of being proactive, thinking about, like, if I could imagine this world, this life where sickle cell care was just what I want it to be, things would be proactive. It's not like, oh, there's a stroke that happened, or oh, your hip needs to be replaced. It would be sort of a conversation that starts from the beginning, for us to like also include specials like palliative care, and thinking about not just the management of the symptoms, the management of organ manifestation, but just of life. And so being able to talk, hey, like, you're, as a 5-year-old, you might have a lot of pain, and this pain might become chronic. Let's think about this in advance. Here's how do we connect people to therapists. I didn't have a therapist, like someone else said, till I was much older, and I didn't realize how much having pain had impacted my psyche. And so thinking about ways to be proactive in terms of meeting a need before the need has happened, because we know it's going to happen. We've seen how sickle cell has progressed. So how can we integrate a way that it's the support is being provided ahead of time? Like, hey, we have these resources for you in case this happens. So that's my thought.
I think that's fantastic, and I know that we are most likely running a bit low on time, coming in at the end here, trying to keep it. But I am curious, as we begin to wrap out, we've talked about how we are so much more than our disease, and that helplessness, and people have heard me say it many times, helplessness is learned, and it can be unlearned. We can grow and go beyond. We can move beyond the helplessness, and one of the things that I'd like for us to leave with here is we're in a room and we have partners and federal agencies present. And what does it look like? In what way can we partner with those present with the agencies to address that we are so much more than this disease, and we can improve quality of life? What is that one area where you would want to see QOL improve for this sickle cell community? And how, if you have any thoughts on how federal agencies or other partners, even employment agencies, but more than that, how can, we've heard from ACEP, we've heard from so many different entities in the room. What can be done to recognize we're more than the disease and improve? What's that one area in a perfect world? We'll start here with you.
Just one.
Just one. Just one.
So I don't know if this is going to answer the question exactly. I think this is like a higher level, like a theoretical concept, but I really think it boils down to seeing us as whole people, seeing us as someone, and I felt this as a kid. When I would talk to my doctors, like they asked me how school was, they asked me what I wanted to be. I want to be a doctor. I felt seen, and I think there's a level. I no longer feel seen. Like once I transitioned from pediatric to adult care, I just stopped feeling seen, and I think in the way that we have empathy for certain disease groups, I would love to see that same empathy applied to sickle cell warriors. And I think there is this is only a thought, but I think there is a level of complacency, like there is an acceptance that sickle cell warriors will suffer. And I think sometimes that allows sickle cell warriors to get sicker than they actually needed to be. If we could see that there is a person behind it, there's a mom, there's a daughter, there is someone who wants to start a business, there's someone who wants to work in a cool tech position, and so being able to have empathy and see the humanness in that way, I think would actually, what's that word, like domino effect into how well we're treated afterwards.
I couldn't agree more. See us as people and believe your patient, because this is a thread that I've heard quite a bit lately. Before here, I was in New Orleans at the National Society of Genetic Counselors, something like that. And that came up a lot, that the conversation was, oh, it's just another sickle cell warrior. You should expect to be in pain. I actually heard a physician say, expect to be mistreated, and go in with that expectation, which is not something I'm willing to do. I won't settle for that expectation.
Yeah.
And I think the thing about not feeling seen, I hear that so much, and we sort of become invisible. And I think that there's a part of us that also does not want to be seen, because if you notice me here, you have an opportunity to treat me horribly. And I think that's a very strange dynamic that we find ourselves in. And wanting to be heard, but maybe not entirely seen, is a difficult place to be in. I'd love to hear your thoughts as well.
Well, personally, I believe that going back into the whole employment thing, that there should be some type of policy incorporated in the same and standardized in the same way that paternity and maternity leave has been incorporated and standardized, that it does become an issue in which you can scroll to that page and this is the policy that we have for, say, sickle cell disease patients or caregivers. And also, I think that mental health is another aspect that we can all do our part in and improve, not only because mental illness exists, but also because there's mental illnesses that come from an underlying issue that can be sickle cell anemia.
And I think that there are most likely partnerships that can be made to assist with that. And what are your rights as a warrior? And how can we address the mental health? But also, how can we address that? And it used to bother me as a child. I don't know if they still do this, but there used to be a pizza party with the principal if you had perfect attendance. And I knew I was never going to have perfect attendance. That was never going to be a thing. And I think we are still dealing with those politics at work. But we are going to end up sick, and perhaps there are federal agencies or partnerships that we can make that will enable us to address that, because it's an assumption that's made that, oh, warriors, they don't want to work. But most of us do. We are all things that all people are, and we want the same lives and the quality of life of others. Mariah?
Yeah, I love this question. So before I come to these talks, my 3-year-old daughter, her name is Autumn, she always goes, "Mommy, go save the world from sickle cell." And if I were to put her in the doctor's room, maybe the doctor will listen to me a little more, because, clinically, you wouldn't have removed that pain management from that hospital, because I can't go save the world, as she says, if you took my pain management away. I can't do that if you're not listening to, maybe I should try another disease-modifying therapy because of the price of my insurance. Those are the things that clinically, are not discussed in the office, are not discussed in the hospital. Going back to mental health, your mental health affects your physical health. a doctor not asking me, well, did you feel, how you have depression or anxiety or anything that could have triggered a crisis. So those conversations and what, my daughter wants me to do, I can't, because clinically you didn't address it, you didn't talk about it, and you didn't bring it to the table. So in a perfect world, I wish clinically this quality of life standards could be implemented more.
Thank you. I would agree with all of that. I think for me, what matters most, and this went a different direction than I anticipated, because we've had these conversations before, this particular group, and every time we come up and we have a very different conversation. And today it seems to be about being seen, about believing us, about recognizing that we want the same quality of life as everyone else, and that we want to be able to gather that and walk into our lives as whole people and seen as such. We are out of time. We have 2 minutes. So I think that very, very quickly, as our last thing, and we talked a little bit about providers, and I want to wind down with you. You mentioned a little bit of loss of identity, and this is a conversation that we're having a lot now, almost to the point that it's dominating other discussions with the curative therapies, and I know that we're working to make sure we discuss other things and the transformative therapies. But I do think it's important to recognize that not everyone is going to be happy with, you said, am I happy to get the transplant, and now I'm happy that I've had it. Can you talk a little bit about that and help us to understand what was going on there in your mind?
Yeah, that's such a good point to bring up, because I think there has been a lack of transparency in terms of what to expect about after transplant or gene therapy. And thankfully, I did my own digging. I was like, I want to know everything that can happen. And so I feel like, and my providers are very honest and open with me about what could happen. But I do think I don't want anyone to get sold, to look at something through rose-colored glasses. I think transformative therapies are something to approach with eyes very, 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 very wide open. And I think there is a lot of potential for amazing things to happen, especially if we start these conversations earlier, so that people aren't rushing to get this treatment done because they're at the end of the rope. So I'll leave that there. But I will say, even after the transformative therapy, there's so much to go through, because you do have to reckon with yourself. If it does work, am I a warrior anymore? That was something I really struggled with. And also, I remember when I was engrafting, I was like, oh my gosh, what if I don't engraft? Like, what if I have to come back to life? I told all these people I'm getting this transformative therapy, I'm documenting it. For me to come back and say, actually, it didn't work, is very hard. And I honestly I can't imagine it. It scared me. And that's something that I think should be discussed more, because it could fail, and that impact on your mental health and your psyche, I just can't imagine how deep that would be. And so, I'm sorry, I have so much more to talk about. Hopefully we can have a panel on just gene therapy and transplant, but yeah, those are my thoughts.
Thank you for that. I think it's really important that we remember that side of it as well, because I hear people say, well, why wouldn't you want this transplant? There's a lot of reasons, and it's okay. It's okay to want to go after transformative therapies, and it's okay to not, because there's so many thoughts. And I was in the middle of mine, and my donor dropped out. And that in and of itself, that idea that I'm about to have this cure, and now, no, you're not. Or I went through I did oocyte. I did pop some eggs on ice, as they said earlier, and I went through all of that process, and now it's just gone. And what if it doesn't work? What if it does? What does it mean that it does? Opportunistic infections. And I would encourage everyone here not to underestimate the intelligence of this community. We may not know the term we may not all know the term, vector malignancy. We may not be able to say those words because it's a very different language, but this is an incredibly intelligent community, and this is a very complex conversation. Quality of life, transformative therapies, all of it. There is so much that goes into it. And so as you go back into your lives, I would encourage everyone not to underestimate the intelligence of this group and not to underestimate our ambition, our will, our goals, our desires, and the way that we prioritize quality of life, because we've lived with death hanging over our heads our entire life. And so the way we see the world is through very different lenses. Talk to us, see us as people, and learn what it means to us and how we can all work together to improve the lives of this community around the world. So that's it.
All right, I am honored to introduce our final keynote of the day. Dr. Titilopa Fashipa is a warrior, a pediatric hematologist, and the SCD specialist and advocate from Houston, Texas. Dr. Fashipa is an active member of the American Society of Hematology and co-director of the Sickle Cell and Thalassemia program at Texas Children's Hospital, and a true inspiration. Welcome to the stage.
Thank you for the introduction, the very kind introduction. I am not as confident as Dr. Ivy, so I'm not going to be able to walk across the stage like he did. I'm going to stick right here and rest with the podium. I have to say thank you to Secretary Becerra, thank you to Admiral Dr. Levine, and thank you to Captain Dr. Wong for allowing this day to be possible. We really appreciate having this sickle cell disease be prioritized in this way, so thank you so much. Am I supposed to aim it at? Okay, good. As she said, I'm a warrior from Texas, and I'm also representing the American Society of Hematology, and I want to thank them for their support. So let's start with the story. Thousands and thousands of years ago, when the Sahara Desert was actually not a desert, it was more tropical in nature. So it had beautiful plants, it had water, and it had, of course, mosquitoes. And those mosquitoes, some of them carried a malaria parasite. And if you can look at that picture, the one of the red blood cells by the mosquito, the malaria parasite did damage to red blood cells, and it caused individuals to become very sick. And then one day something changed. There was a special child that was born, and that child had a superpower. It was born with a mutation in its hemoglobin that allowed it to survive malaria, to do better when other people were not doing better. And that child passed on that mutation to generations. Now, in an odd twist of fate, right? Every good story has this twist to it. When you inherit two amounts of that superpower, you end up paradoxically affecting the red blood cells in a different way, also causing damage. But I will say, you've already noticed this today, in addition to the damage, it is still a superpower. You will see that these individuals have inherited a double dose of brilliance, a double dose of beauty, a double dose of courage, a double dose of resilience, and I don't even know, so many talented warriors. But this is the origin story of sickle cell disease. And millions of people have it worldwide. It came to the Americans first through transatlantic slave trade, right? And then after, we've had migration patterns of different kinds around the world, so anybody can be affected with sickle cell disease. In the country of this country, United States of America, we say that there's about 100,000 people with the disease. Well, contrast that to Nigeria, which has the most sickle cell disease in the world, and 100,000 babies are born annually with sickle cell disease. Just let that sink in. In 1981, I was one of those babies. My parents did not know I had sickle cell disease. There was no newborn screening. And so they found out I had sickle cell when I had recurrent pain crises. And it was around the time of my first birthday that they realized that their daughter had sickle cell. Now, my name, Titi Lokpe, that's how we pronounce it. Titi Lokpe, that musical way of saying it, it means forever grateful. And first, they named me that because I was their firstborn child. They were excited new parents. But my name became almost like this self-fulfilling or this prophecy of sorts, as names tend to be. And they found themselves being forever grateful just because I was alive every day. Because in our culture, children with sickle cell disease are referred to as children who come and go. You heard earlier when they discussed the myth and the legend, that was what they were dealing with. And so when I was a young child, my parents came to this country, and one of the first things they did was take me to a sickle cell clinic, and they asked, "What do you do for sickle cell disease?" And they got the answer, not much. Just keep on taking care of your daughter and good luck, basically. I didn't know at the time that there was people like Drs. Gasta and Drs. Reed doing the work that would end up saving millions of children. And so some of us who are alive, that have passed some of the generations of these excellence, it's by chance. And so I had a very isolating experience as a child with sickle cell until I moved back to Nigeria at the age of 11, and I met other warriors with the disease, and including my cousin. Now, she sadly passed away at the age of 17, and that actually was what inspired my journey into medicine. I was like, people shouldn't be dying at 17, and she was vibrant and beautiful and smart. I just couldn't understand it, and I first thought it was a problem of Nigeria. Oh, the healthcare system. Surely America would have it right. Well, I got into medical school in America, and I had the rudest shock of my life. My parents had kind of shielded me. I didn't really understand what it meant to be a sickle cell warrior in America, similar to what Christelle said, until you get to adulthood. And I was told by medical professionals that I should never even think about entering a space where you take care of sickle cell disease because they are drug addicts. And I realized that sickle cell was a boogeyman for the medical community. It was ugly. It was not worth saving. It was not worth helping. And I saw that my limited medical education about the biology and the hemoglobin S, that was not enough to understand sickle cell disease. This is a question many of us ask ourselves. How do you solve a problem like sickle cell? And I realized from medical school and later residency and fellowship that it's not enough to understand the biology of the disease. We really have to understand this problem, this beast of America, the systemic racism, the inequities that we see, the long-standing disparities, just all the various elements that people suffer. I said the crisis of sickle cell is not just the pain, it's the society, it's the community, and it's a travesty. This painting was painted by the late Hertz Nazaire, who was mentioned earlier today. And for those that don't know who he is, he's like our Chadwick Boseman, y'all. And if you don't know who Chadwick Boseman is, then we need to talk after this. But what I saw with him is that he made sickle cell beautiful, you know, and I felt seen. That was the conversation that was in the last panel. This is my favorite painting of his, and it's sad that it's of a child crying, but it means so much because I felt seen. You recognize the pain, and I feel like the pain is more than the pain crisis. It's the fact that you're not being seen. So how do we solve the problem like sickle cell? You have to redefine the problem in its full effect. This is a very brief and incomplete timeline of the history of sickle cell disease. And you saw a few timelines and heard reference to some shout outs of high points in the history. Well, the point of this is not just to shout out advocacy, it's also to show the disparity and the gaps. So in 1910, sickle cell is so-called discovered in the United States. And by the way, it was discovered in an immigrant, not an actual person who was an American, because it just was, again, a disparate time and continued to be. Fast forward to the 1970s, you get a Sickle Cell Act that led the way, and you heard Representative Davis and others talk about it, led the way to starting to begin the health and human services, and the government to start to appreciate the problem of sickle cell disease. It was a start, right? And so you have the first act in the 1970s, and it wouldn't be until several decades later that you had a second act. And then, thankfully, the last decade, we had a third, and we're working on a fourth, as you heard the representative discuss. And so what other disparities do we see here? Well, I put on there that Texas, they started newborn screening. They mandated it in 1983 for sickle cell disease. And we were not the first state. New Yorkers know that they were the first to start mandating sickle cell disease screening. When did we start having universal screening? I think you all remember the date it was mentioned earlier, 2006. 2006. So from 1970s, which is when New York started, to 2006. So we need to recognize that even with our progress, the progress was stilted and halted by the fact that this disease was not being seen and appreciated. And then the other piece I'll say about this is I listed clinical guidelines. I also put when drugs were approved. All right, we talked about hydroxyurea a few times today. It was approved for use in sickle cell disease in 1998. 1998, okay, and that's, as Dr. Campbell said, 90 years after it was so-called discovered. For a disease to have a drug, it took that long, right? Dr. Ivy started it a few years before it was approved, so he was one of those brave people that are like, okay, let's just see where this goes. So then 2 decades later, you finally get more drugs that were approved, and then now we're living in a decade where we have gene therapies approved. I am happy, but it's still painful to see the process of progress in sickle cell disease and how stuttered it is, how difficult it is, how challenging it is. So I started reflecting on this a little more, and I was like, okay, there's various analogies that we can use, and I decided to look to elephants. There's lots of things about elephants. Elephants are wonderful creatures, but there's 2 that I'm going to focus on. The first is we have to address the elephants. When people say that, they mean address the thing that's glaringly big and clearly the problem, but we refuse to acknowledge it. We ignore it. You have to address all the various elephants that is in the history of sickle cell disease, the history of neglect, the history of the systemic racism, just all of it. You got to address it because people will not begin to trust you until you see that they're being taken seriously. So you're addressing the elephants, and an interesting happens. You finally start addressing it, but you probably know the story of the blind people trying to touch the elephant, and one only feels the tail and the other one feels the trunk, and so forth and so on. Well, your piece of the elephant is not the whole story. Okay, so not only do you have to address the elephants of the travesties, you also have to respect the fact that we all have different things to bring to this greater picture, and you do not have all the answers. There's sometimes this paternalistic and condescending way that the healthcare community and the research community approach sickle cell, and you heard this over and over again today. Please, please make sure you realize that you're actually touching a big organism. So how do you solve a problem? You redefine the problem, you call out the issues, and you give yourself a grade, right? You get down and dirty. There are so many examples of this. I picked out a few, so I give a shout out to the Sickle Cell Data Collection Project. Now, you'll note that they mentioned they're in 16 states, which is progress, but we still need to do more. But they're now counting individuals. Every time they say 100,000 people, I sometimes I'm like, okay, I don't know. I don't know how many people we have in this country with sickle cell disease. We don't know. That number is from 2010, y'all, by the way. And that number was also incomplete because they gathered it from insurance data and newborn screening. So just know that we need to do the work to actually figure out where the scope of the problem is. In 2016, the American Society of Hematology had a summit of sorts, and they gathered people together and released a state of sickle cell disease. And it gave a report card, and it was full of D's and F's, y'all. And it was good. I was happy. I was like, yes, call out the problem. You know you're not doing a good job in this space, and it allows you to appreciate what you can do to get better with the problem. And then one of the things that made me like the way I feel about today, well, in September 2020, when the NASM sickle cell disease report came out, that big 300, 500-page document, I was so happy because it summarized this history lesson. It showed us all the various problems, and it gave us a strategic blueprint. And I now hear it being referenced now more and more between the various HHS agencies. And so I'm very happy about that. And then I wanted to give CMS a shout out. They released a sickle cell report in 2021. It showed what many of us already knew. People weren't getting penicillin, people weren't getting transcranial Dopplers, but it was good that they are now starting to take account of that. This is quite important. All right, this is my last slide. And it sounds Pollyanna-ish. Pollyanna, maybe, let me use another acronym. Okay, people don't know Pollyanna. It sounds maybe too happy, sunny, sunny. Together we can. What does this really mean? I want you to think about each talk you heard today. There was a message, not all of them used the word, but they were basically saying it with their speeches and with their conversations. There's a message of accountability. First, you may not see an organization you identify with here, but I hope many of you at least resonate with one or more of these organizations. First, each of you have a different piece of the elephant. So be careful how you speak to others in other spaces, and be careful when you think about what it looks to partner. Appreciate that your fellow agency and your fellow co-partner or whatever might have a different perspective that could be beneficial to you. We're not always gonna get it right, we're not always gonna get along, but you need to appreciate that everybody can do part of the work. The other thing that you'll notice is that I don't have a lot of community-based organizations, partly because they're the choir. They know what the elephant looks like. They've drawn it multiple times. But you didn't realize it was an elephant when they were drawing it, but that was what they've been telling you for years, right? Okay, so I pointed out a few, but I wanted to just let it sink in that it is an essential ingredient. And it's only now in the past maybe 2 decades that I start seeing community-based organizations, warriors being at the table. I also loved some of the earlier panels, that representation that they mentioned. It also helps when people look like you at the seat at the table too, okay? They help define the problem more holistically. My last few words are to just revel in the awe of what just happened a few moments ago when Dr. Clarice Reed was presented her award. And y'all, we got like three legends on the podium. We had Dr. Gaston, we had Dr. Clarice Reed, and we had Representative Danny Davis. They were there back in the day. All the history that we're dancing around about, they saw it come to action. They saw it when it was nothing. They are the legacy, people like them, and you know very many more. They are the legacy of sickle cell disease advocacy. We are the promise. And this is not, again, a cheerleader speech. This is to go back to the word accountability. We owe it to the individuals in this country with sickle cell disease to do better for sickle cell. We owe it not to be lazy or complaining about it. We owe it to increase funding. We owe so much, and it's a debt of gratitude to this legacy. So as my name says, I'm forever grateful. I am very, very grateful, one, to be in a room with such amazing warriors and to just feel uplifted, but two, to know that our federal government is listening, and I hope, I pray that they will continue to listen. Thank you.
Hi, good afternoon. In the vein of people who look like you, I'm probably not going to meet that standard, but my name is Lynn Shaw. I know some of you from some of my work over the last year or so. I'm in the Secretary's office. I'm one of his counselors, and as one of his counselors, I have the immense privilege of getting to work on sickle cell disease and sickle cell trait. And I want to first and foremost thank you all. Give yourselves a round of applause, please, because you got here very early in the morning on kind of a not so pretty day to talk about, lift up, and raise awareness and fight for change in this condition that we know deserves so much more attention, so much more resources than it's gotten. I have the immense privilege of closing us out. And I want to just say a thank you to so many of the people who put this together, who worked with us hand and foot to get this across the finish line. First, can we give a round of applause to David Wong and Zainab Jama at IEA. As I told the Secretary and our Chief of Staff, David and Zainab have been emailing me and calling me basically almost 24/7 for maybe 3 months, all day, all weekend. They have really poured their hearts into this for you all. Zainab was just telling me, I hope I don't embarrass her too much, that this was really, we wanted this to be for you all, for the sickle cell disease warriors here and in our country. So I won't speak too long. I have a long list of people to thank, but I did want to say a few things. As I've learned about sickle cell disease from you all, I want to thank you all for being our inspiration, for being such resilient fighters, for being our teachers, and for teaching us that you need and deserve a better ability to thrive. And we've heard you, and we'll continue to fight alongside you. There's just so many issues that we would want to tackle if we had all the resources in the world, and we count on you to give us additional feedback over and over again. Let us know when we're getting it wrong and when we're getting it right, so we make sure we can course correct. One of the things that I've heard from the Secretary over and over again is that sickle cell disease warriors and their families have been waiting too long. They need change. They needed it a decade ago. They needed it yesterday. We can't let them wait any longer. And that really comes from him. I was really heartened to hear some of our panelists say today, sickle cell disease warriors and their families, you just shouldn't have to fight this hard. You shouldn't have to look for resources for this hard. And it shouldn't have to be this repetitive as you explain what you're going through. And so we are committed at HHS to working by your side and fighting for you, and fighting with you. Just so much work that we still need to do. I think one of the things that we really are hoping to tackle in the next few years or in the coming decade is to figure out how we get our arms around this pediatric to adult transition, for example. Dr. Fasipe alluded to the fact that we are collecting data in 16 states, but why not across the country? There's so many things that we should be doing more of. Mental health, making sure our folks have access to therapy. So there's clearly a lot more work that we need to do, and we count on you to do it with us and fight with us, and we look to you for our inspiration. So with that, I won't keep you here any longer. I just want to go through a very long list of people to thank. Can we thank our MC today? From OASH. We fondly refer to her as Lizzie, but Elizabeth I'm going to say your name wrong, Lafayette, has been with us through this fight and has been pulling this boat with us. I'm going to run through a list of agency names. A lot of them were on the screen you saw before, but the Office of our Secretary, IEA, OASH, ASPA, ASL, ASFR, which is our financial offices, NIH, HRSA, Offices of Minority Health, and the Partnership Center. These are all agencies within HHS who have helped with the summit or helped with sickle cell disease work along the way. I also want to give a really special thanks. Can we give a round of applause to our sponsors today? They were the folks responsible for making sure you had breakfast and snacks, coffee. That would be KMD Advocacy Center, the top ladies of distinction, who also provided blankets and hand warmers. Thank you so much on short notice. The William E. Proudford Sickle Cell Fund, who also helped with snacks and pastries. So thank you all so much. And Miss Vaughn, Simone Vaughn, if you wouldn't mind standing briefly, we wanted to recognize you, Nakia Vaughn and Shimon Vaughn. If the three of you could stand up, could we give them a round of applause, because Simone and Shimon are sickle cell disease warriors. Simone she's 12 years old, but she's mature beyond her years clearly, and has been drawing throughout the summit. And we're going to now auction off a few of her drawings. Secretary Becerra was lucky enough to get one earlier today. But my goodness, I have to say, Simone, I have a 12-year-old girl, and she would not have sat there as well as you did with so much poise. She's going to kill me for saying that. Okay, so we have here everyone who put their Post-it notes. Thank you very much. We're going to auction off this first drawing. Simone, do you want to come up and share these with folks? You're welcome to come up and pass this on to folks. I'm just going to close my eyes and pick one. Okay. I'm putting Simone on the spot here. All right. Is Kimberly Davis here? Did we lose Kimberly? Does anyone know? Oh, great. And then I'm going to pull out the next one. We have... He fortunately left us a number in case he had to go early.
Gabriel George.
Mr. Gabriel George. Oh, yay! Christiane Olivero. Yay. Can we give Simone another round of applause for everything she's done? Okay, we're going to have one more. Maybe we'll do one after that.
Rose Bailey Millard.
Miss Rose Bailey Millard, do you want to come up? This is an infographic that all the speakers today signed. So please come. So we are actually missing one or two signatures. So if you want to come up, we will get a picture with you or something, but we will get this to you. Is Miss Bailey Millard here? We will track her down and get it to her. Okay. Thank you all so much, and we hope we get to see you again very soon. Have a great afternoon, everyone. Thank you so much.
Produced by the U.S. Department of Health and Human Services.